This is Heart Rhythm TV, and I'm Daniel Alyesh. Welcome back to the ICE Image of the Month. So our topic is going to be ICE for PFA for VT. And I'm joined today by a good friend and mentor, Dr. Roderick Tung of the University of Arizona. Welcome.
Thanks for having me, Dan. It's an exciting topic, and PFA has swept the world, and I think it's fun to think about what its future applications are outside the atrium.
So Rod, I actually wanted to, I was thinking about this, 4 years ago probably, you were the chair of Heart Rhythm TV, and I was there on your subcommittee. And you came up with the name Ice Image of the Month. I said, hey, we need to profile interesting ice for the general EP community. And it's grown into ice, not necessarily of the month anymore, but I got to say, what a good time and so great to have you back on the program that you helped me name.
Well, I think ICE is probably the greatest advancement that we've had in my shorter midterm career here, because think about it. We used to start with ICE as a mechanism to facilitate transeptal puncture and as a modality to just make sure we don't have effusions. And what we do now with ICE with the recognition of intracavitary structures, monitoring lesion formation, monitoring pre-steam pop, right? Understanding correlative anatomy with burning Gerbode defect regions of RA to LV. This is all afforded by ICE. So I think it's made us so much better as a field.
Oh, absolutely. And especially in the ventricle, because of the complexity of the substrate, complexity of the anatomy. So just for the viewers, this is part one. We're going to focus today on VT and PFA and ICE. And part one will focus on large and middle footprint. Okay. And we have a couple example cases of that. And the first one we'll start off with is, Rod, you published this a while back here. The first in US application of PFA with the pentaspline catheter in the ventricle. And it was a case of yours. I think it was a 3-do ischemic VT, two prior RF, 74 applications, and you terminated two separate VTs. First off, comment to me a little bit about your calculus for going for PFA in this patient and a little bit about the case.
Well, there's actually a beautiful story because the third author, Dave Banning, who's one of our senior techs, we said, we've got an incessant VT. And he goes, oh, so you'd like me to get the Farapulse ready? And I was like, no, I said VT. And he goes, oh, I know. And he goes, well, you don't want to see if there's an application. So I loved that this was more group thought for trying to understand this. And because it's a 3-do that was refractory to RF, we were curious about the potential feasibility and efficacy of a different technology. And we talked to the patient very carefully about the fact that we have this and we've had great outcomes. Wilbur Sue was one of the first in the Western United States to commercially launch Farapulse with us in here in Phoenix. So a lot of credit to Dave Banning. And we were thinking, well, wow, for an apical infarction, because we know there's not a lot of steerability, this is the perfect place to try to go and put a basket or a flower configuration and press it into the apex.
And I saw you comment a little bit about you were able to see diastolic potentials. Now, the resolution of the Farapulse catheter, is one of my one of my quips with it, but you were able to see good electrograms, right?
Exactly. And in this figure, what you have is a high density map with a traditional mapping catheter with a grid configuration. And then we show the electrograms of VT1. And you still do see the diastolic corridor. You do see some buffet elements, right? But they are less near field. But still, the presence of them is great. But we have to remember that when we're mapping with these larger footprint catheters with wider electric spacing, the electrograms will be different. Voltage criteria are different as well. And even annotation of late components will be different as well. But what we have here is an actual HD grid mapping catheter and then the electrograms prior to the pulse.
Great, great. So I'm going to jump to our first image here. This is a compilation of your different ICE images. Um, and, it looks like you're imaging from the RVOT. And I think, the anatomy of the ventricle and the size of the flower and basket conformations, I can see how ICE can be critical. So why don't you tell us a little bit about your image? How did ICE lend to value here?
Well, we love this view not only for monitoring the ventricles. So we typically, when we go in, we want to see that sheath, right? Cannulate the mitral isthmus and not get into left atrial appendage. So we have a deflectable sheath, we get in, and the minute we cross the annulus, then we go into the RV, clock that, and here you can even get to almost a short axis aorta, do a little bit of leftward tilt, and then you actually see the septum. And we love this for even intraseptal scar circuits. And sometimes we see a beautiful mid-myocardial stripe with ice. The concept that we have to have MRI ahead of time, I think that ice is quickly supplanting MRI in cases where it's inconvenient, not able to. We just published this peri-aortic paper by Sahara et al. In JACC-EP that showed that wall thinning on ice was the best way to predict peri-aortic with comparison of MRI with Core Lab with two of our imaging that were blinded to this and that a wall thickness up in that basal anterior. And here you can see some of that here. You can see the anterior infarction. So love to see areas of wall thinning. And then with the introduction of the catheter as you're playing that, we're going over the wire, getting into there safely, and then curving this upward to address the regions that we had mapped there. And then here in this situation, we wanted to try to get full apposition of it. So we thought that a flower configuration would be better than a basket to abut and oppose and try to get 5 or 10 grams of force, as Hiroshi Nakagawa has taught us, that this is not a non-contact technology. You still need sufficient contact to be able to create a good lesion. And you can see we're
So,
in VT, which is what's fun about this ice.
oh yeah, and you're applying PFA there.
Correct.
Um, I'll tell you that I'm gonna get a call from my mentor, Frank Bogan, when you talk about MRI being supplanted by ice. I mean, I actually was just at Michigan a little bit ago to give the fellows a talk on echo, and he came to my talk and we went back and forth about this. I think ice is huge. I still get MRIs when I can. I think, a lot of ways to predict your substrate and then pre-procedurally as well as in the procedure. And ice is, as you said, so critical. So critical. Talk to me a little bit about, so now we got your Farapulse ice here. You're applying your flower applications. Tell me about philosophically, you know, I think I even talked to you right before you did this procedure, to be honest. We were talking about some heart rhythm TV stuff. You're like, I'm gonna go put the Farapulse in the ventricle. Why not? Now tell me about your thinking now. Now that we know this is a catheter designed for, for PVI, the depth that we're achieving, where are you with your thinking for using pentaspline in the ventricle, if at all?
Well, we've learned a lot, and there's so many sessions about whether PFA is going to obviate the need for epicardial AFib and if PFA is going to be great for the ventricle. Well, just to remind everyone, the PFA sequences and all of its technology has been obviously designed for pulmonary vein isolation. And even outside the pulmonary veins, we're starting to see limitations. There's a great paper by Lafaza et al. With Natali's group in Circ AE just in August that showed that the durability of a inferior mitral line and CS isolation is single digits. I believe it was somewhere around 6 and 8%, which is the lowest I think that Andrea has ever published, right, of showing the outcomes. And it's a call for people that continue to do lines in the atrium to think that these are durable. While we might get acute termination or suppression or some stunning, the promise of durability does not appear to be there in regions that it was not designed for. And that's where
Yes.
the creep, right? Is that we get interested in this and we want to kind of push boundaries. But clearly, the appetite is immense when you're thinking about homogenizing large substrate to have lesion applications that could be delivered in less than a couple seconds. So that's the draw for this. And we wanted to know how deep it would go. And as the electrograms are, this took care of the incessant VT, and the patient actually did really wonderfully, which tells us it was superficial. But what's more important in this paper was the electrograms that we were publishing, because only in one pulse did we see a reduction in lava, late potential, fractionation in that frequency. And we show that electrogram that got reduced. But the other ones after the pulses appear to be unchanged. Now, of course, these are larger antennas that we're seeing, but if it's indeed transmural, which it does not appear to be, you would see an elimination of electrograms.
No, I agree. I think that the large footprint PFA is designed for vein isolation and maybe a little bit beyond that, but probably just vein isolation. And I think that the other technology or the other footprints um, may have a different potential. And so moving on to another case, and we'll preface it with AVAR, which is the European registry of the lattice tip catheter for VT, VF, and PVC. 126 patients. These are all redos, about 20% epicardial. And I would say the strength is looking at the efficacy, looking pretty good. The weakness, I would say, is look at the length of the follow-up, not incredibly high. Having had some experience doing compassionate use with the lattice tip catheter and using the Affera mapping system with it, I think from a therapeutic perspective, it's of interest. I think from a mapping perspective, especially in the ventricle, if you're a person that believes in, and Rod, I'm pretty sure I know where you stand on this, if you believe in a functional understanding of your substrate as a critical component of how you perform or approach ablation, whether it's ILAM, whether it's S3 protocol for LAVA and all these different things, you're going to need to, I think you're going to need iterations of the mapping system to really be able to do that with the therapeutic potential of the Sphere 9. I'll ask you to comment on where you think things are in middle footprint.
Well, and I think that the middle footprint was a great innovation, and it really started historically as a better RF catheter. And then I believe secondarily, it evolved into a dual energy source with PF. And I think that dual energy sources clearly are where the future is going because we understand that spasm has risks. We understand that there's emboli that happen with these pulses as well, and that's been documented. The nature of asymptomatic, events and just signals in the brain, we don't know, but I think all of us would rather prefer to not see them. And in this series, at least, you're seeing some good acute successes, but the recurrence rates are somewhere around 70, 80%, which is probably where current industry standard is these day and age. But we do know how heterogeneous these patients are. Some patients just are probably not great ablation candidates. So it's all about how we pick them. But there's a large incidence of de novos, and those de novos seem to do well. I'm surprised that there were some the VF ones, but what makes sense about VF is we start thinking about targeting the his Purkinje as the trigger for VF. We target the PVs for AF, but targeting the his Purkinje for VF makes a lot of sense, the trigger. But the Purkinjes tend to be much more shallow and superficial. So this could be the best niche for this is to be able to do some modification of the posterior fascicle. Some of the mid to distal aspects of left conduction system are clearly implicated, and even empiric ablation of that can be useful. So this could be a great, great tool for more superficial lesions.
Yeah,
The again, we don't know.
I think if you talk about VF, I think clearly there's a his Purkinje and a Purkinje myocardial issue. I think, in the era of RF, we always said we had to do a little more ablation than we thought. Just targeting the trigger, just targeting the fascicle. And there's a whole concept of denetworking, which I think can be maybe better achieved with the middle footprint. So we'll jump into a case with the middle footprint, last tip catheter. Just to preface the audience a little bit, this is a patient of mine actually that had a prior aneurysmal patch, prior open heart surgery. So it was a redo from RF. Actually, had gone several years without any VT and had recurrence with fast, like beef flutter type VT. Epicardial was considered, but just given the history of the patch and looking at, you can appreciate even from the ice after when I played here, probably a fair amount of adhesion there. So we decided to try the middle footprint and to try to drive deeper. And the protocol that we're doing is a sequential co-localized. So if you look at some of the papers, if you do an RF lesion and then you co-localize 4 PF on top of it with the lattice tip catheter, you can potentially get 1.7 to 1.8 centimeters deep, which I think is something that we would welcome, and maybe we've done bipolar ablations or other things to achieve that. So I'll play the video now. important thing to talk about is looking at the substrate, right? Your ice helps you see calcified papillary, you see your aneurysmal patch. You even can identify calcified papillary apparatus. And you can see that this catheter does really navigate within this substrate and adhere to that papillary apparatus. Here we go. We're going to map the borders of the aneurysmal patch while visualizing it all on ice. And you see how echogenic the lattice tip catheter is. Now, I want to make the point here too. See, as you said, right, anatomy with ice is unparalleled. Moving your catheter throughout the heads of the papillary apparatus. Because I want to just pause that one there for a second, right? Say your catheter is here on ice versus here on ice. Your mapping system, because it's intracavitary, it's not going to tell you that that's that difference, but that's a world of difference from an anatomic perspective. So I think ice here is critical for navigating throughout all of that and really moving through the papillary apparatus. So I think, ice for VT, first you're characterizing your substrate, you're understanding where's the anatomy, where do I want to map, and then you're going to move through that anatomy with ice for an ice-guided mapping approach. I think, I always say that for this for papillary arrhythmias, ice-guided mapping is the only way because you can see how many heads the papillary muscle has, the chordae, and even calcification like you see here.
And just for some historical context there, Dan, because it is beautiful just to pause and look at the intricacy of what we can see with intracavitary in relation to the aneurysm. But if you look at like the birth of EP in the 70s and 80s, other than like Jacques de Backer, who was actually looking at infarcted papillary muscles as models, we weren't really ablating pap muscles, right? And the recognition of pap muscles, their PVCs, then you see a lot of the Frank Bogan work, at your home institution, teaching us about the different LV paps, even the RV paps. This is something that really has come out in the last 20 years in the history of like human existence, right? So this appreciation of being able to target the septal and the lateral aspects and be able to map the tip and the base of it has really been afforded by ice. And that's been an incredible advancement. Can you do it without it? Well, electrograms always will guide you home. I mean, you can still move it into a region and look for regions that are early. You just don't know what you're on always. And you can't always even confirm lesions. So, of course, you can be successful. But having the luxury of being able to see exactly where you are, the contact, watching lesion formation is something that delivers on the promise of what real-time MRI we were hoping for, but clearly less scalable. Unfortunately, ice is still not scalable in some parts of the world.
Yeah, no, I mean, Mansour Azmian talks about how right now ice is like Gucci. If you can afford Gucci, you get Gucci. But
Sure.
he wants it to be more like Walmart, where everyone can come get what they need. And so I think it's a challenge. I'll tell you, I had conversations with Europeans who say, I know ice delivers a lot. I don't even want to look at it or know because I don't want to know what I'm missing. And I really just can't do it. And to say, that's to develop, that's, our peers, they're driving forward and that's their philosophy. I think we have a lot of work to do for
Mhm.
building ice globally. So I'm going to move on to our next. So the next is therapy delivery. Okay. So we showed you, we were mapping the substrate. And now we're going to do therapy delivery with a sequential co-localized RF first and then PFA. And I want to make the comment that, I've generally taken this approach where you deliver PFA after RF because, there are many theories why, but if you deliver RF on top of PFA, we're finding temperature spikes are more frequent as well as potentially steam pops. So what you're trying to drive a lesion that's deeper when you do co-localize. And the order doesn't really matter. So why not do it in an order that's safer? And the lesions are deeper with a potentially a circumferential PFA type lesion with a central RF type lesion. That's the theory. So let's get to the ice images. On ice here, you'll see a little bit of a blanching under the catheter there because that's where the RF was delivered. So you have that edema that you see with the lattice tip catheter. Not as pronounced as when you see, and then you see your PFA delivery on top of that. So it's not as pronounced as when you're doing RF and you're getting that really significant blanching because this is a pre-programmed ventricular waveform. But you do see the blanching. You don't necessarily see blanching unless you're getting partially thermal with the PFA delivery. Um, so these are compassionate use cases. So that means we're using, um, non-approved ventricular waveform. So this is a 30-second RF application followed by a ventricular waveform. So I mean, how does ICE help me? It helps me understand where am I relative to the substrate here. It's also telling me am I having a good RF effect? Do I see that blanching? Do I see that edema? Do I have appropriate electrode and tissue contact when I apply my PFA? And that's how I believe and feel like I've delivered a good lesion. Um, Rod, I think, with the background of ICE as far as informing our discussion, um, I think we should talk philosophically about where is PFA and where is it with regards to the ventricle. I'm very happy to see that, quite frankly, Medtronic shows an interest in designing and developing waveforms and testing them for the ventricle. But where do you think we are with the ventricle and PFA, and where do you want to see it go?
Well, there's no question that the future of VT, if we're on this road to 90, the road to 90% success rates as if it were SVT, I believe we can get there in our lifetime. I don't think we need further iterations of high density mapping because there's so many beautiful maps created around the world on Twitter, et cetera, where you see the whole diastolic buffet. And we're able to now image the diastolic corridor, right, as Paolo Della would say, but we can see the whole thing. So really, at that point in time, it's really an issue of creating a durable and transmural lesion. We also understand that VT is mostly intramural. All circuits have a component of intramurality. And that's probably close to 90% of circuits where some of them are just purely layered on one surface and then focally break out the other. But most of these are all three-dimensional. So to be able to penetrate across is really everything. And being able to find the most arrhythmogenic areas are it. I just believe that we're not there yet, but clearly there's a lot of hope as now that atrium has been very favorable for pulmonary veins, we still can't extrapolate it to the mitral. So that's why I don't think there needs to be a lot of discussion about the ventricle with current iteration. These success rates are great, but they don't exceed, right, those of traditional. And when you combine energy sources, scientifically, you don't know which one is the one that actually got the job done. And you can't cross over an individual patient. I would also just add to your sequencing, which is that obviously if you do PF before RF, your electrogram has a greater chance of being changed or altered in a less durable way, which then puts you at RF. And you don't want to ablate no electrograms, right? Because then it's purely electroanatomy. There isn't even electro, it's just purely anatomical. So I'm looking forward to it. You know, Field Medical and Steve Michelson's team are specifically trying to look at VT pulse sequences. I know that Abbott's trying to look at specific pulse sequences. There'll be iterations on Afera. You know, I'm hoping Boston Scientific will follow suit there as well. And I think that the time is for us to get transmural therapy. And whether that's with a needle, whether that's with ultra low cryo, or VT specific pulse sequences, which are not currently yet available commercially, that remains to be seen, but that's what's exciting.
Well, Rod, yeah, I agree. I think we've come a long way with regards to mapping, understanding anatomy. Now, our therapeutics, we've spent a long time taking our 3.5 millimeter irrigated tip radiofrequency catheters and trying to do a lot with them. I think the therapeutics, it's a time for therapeutics, and it's a time for focusing on this substrate, which I think has a tremendous upside for the patient. So, very well said, Rod.
Well, thanks for continuing this whole ice image of the month. We've shown many today, but I think that's what people love to see. It's such a visual field, and we love to see exactly what's happening with all of this. And I agree with you. The safety of being able to see if you're really pushing, if there's tissue apposition. We've even changed it where no lesion on ice, no red dot, right? Because why are we putting dots in blood? Like until we see something go echogenic or something change or you've got effective tissue contact, there's no reason to annotate that as an effective therapy site. So been really transformative in terms of how we've done it. And it's fun to watch your own style and the own way that you've been trained and how that evolves even within one lifetime and one career. And I think the young ones in EP, the ones that are growing up, clearly have a lot that they're taking for granted in a great way.
All right, Rod. Well, thanks again. So this is part one. Part two, we'll focus on focal application of PFA and associated ice. Ross, thanks for joining me, and thank you all for tuning in to Art Rhythm TV.
Thank you.